Okay. Good afternoon, everyone. I'm presenting on behalf of Medicine One. My topic name is the Constellatus. We had a patient admitted under us, Mrs. M, who presented with a history of right hip pain and lower back pain for the past 2 months, which is associated with inability to extend the hip. She also gives a history of slip and fall from the chair 2 months back, post which she had all the symptoms. She also developed high-grade fever with chills and rigors 5 days prior to the admission and present to the ED with the following complaints. She has no known comorbidities. On examination, her vitals were stable and her systemic examination was normal. Pallor was present. There was no icterus, cyanosis, clubbing, lymphadenopathy, and edema. On local examination, we found that the attitude of the right lower limb is there is flexion at the hip joint and the knee joint with associated pain on extension, and there is tenderness at the inguinal region and right iliac fossa. So with the present history and examination findings, which is fever with inability to extend the lower limb, our first differential diagnosis was right psoas abscess. We also consider the possibility of retrocecal appendicitis, where there would be a minimal tenderness, but fever and inability to extend the lower limb, and so that is a psoas sign would be present. Some septic hip arthritis can also present with similar picture. And our last differential considered was psoas habentoma. So on lab investigations, we have found that she has neutrophilic leukocytosis with toxic changes. The renal function and the liver function test were normal limits, and she was also found to have iron deficiency anemia. Ultrasound abdomen was done to rule out the above said differentials, which showed a large heterogeneously hypoic collection arising from the right psoas muscle, extending laterally till the lower pole of the right kidney, with peripheral vascularity and few air foci. So at that time, we have done a blood culture, and blood culture grew Streptococcus constellatus. So she was started on antibiotics, and for source control, pigtail of drainage of the abscess was done. We have also done a CT abdomen, which reveals an L4-L5 spondylodiscitis. So our patient presented with L4-L5 spondylodiscitis with right psoas abscess. So whenever we see such presentations, our first differentials would be bacterial, and the most, that is 97% of it, is caused by Staphylococcus aureus, and the other 3% can be E. coli and Streptococcus. Sometimes even Mycobacterium tuberculosis, like in an predominant places like TB, where in India, where TB is more predominant, we can also see Mycobacterium tuberculosis causing a right psoas cold abscess. Then other rare entities that has been reported in few countries are Klebsiella, Salmonella, Candida, Brucella, and Nocardia. So psoas abscess, there can be a primary psoas abscess which occurs because of hematogenous or lymphatic seeding in an immunosuppressed patients, usually seen in younger population, whereas secondary psoas abscess occurs from direct spread from an adjacent structure. So the risk factor will include trauma and instrumentation. And the right psoas abscess, so it is an emergent management. We have to do an emergency management because of the risk of sepsis. They can also present with DVT because of pain. They're usually immobile, can present DVT. And the abscess as such can compress the ureter, causing hydronephrosis. They can also cause bowel spread to the hip, causing septic arthritis. So a little bit information about Streptococcus constellatus, which is actually a group of, it is a distinct species of Streptococcus milleri group, which is a member of Viridian's group of Streptococci. So other than constellatus, there are other two species also which are included in Streptococcus milleri group, which is the Angiosus and Intermedius. All of us have come across the Angiosus group, which usually presents with abscesses in the dental abscesses, and can also present with prosthetic valve endocarditis in case endocarditis. So now other species in this group is Constellatus, which is also a part of the normal flora of the human oral cavity. It is a facultative anaerobe, and the distinguished feature is the ability to cause abscesses. Usually they are non-pathogenic, but in case of people which are who are immunocompromised can present with abscesses. They can also, so the spectrum of abscesses in this population would be odontogenic neck infections, brain abscesses, hepatic abscesses, can present with hepatobiliary intra-abdominal abscesses, and occasionally lung abscesses and empyema. So if you see, angiosis is most commonly associated with endocarditis, whereas constellatus is most commonly associated with formation of empyema. So in our patient, we had a psoas abscess formed because of the Streptococcus constellatus. So the exact cause of the virulence of this organism is not yet known, but then there is a documentation of production of polysaccharide capsule and tissue damaging enzymes. So the abscesses are usually located in the viscera, and the predisposing factors for their formation include either an compromised host defenses or disruption of the mucosal barriers. So it is often when we see a patient who has come with fever with bacteremia, so and we take cultures for them, it is usually difficult to distinguish this group as a contaminant or an offending organism. And even if we come across the, even if you localize to Streptococci species, it is very difficult to distinguish between Constellatus from intermediates. And the main culture is the most common means of detecting the bacteria, and the treatment would include source control and use of antibiotics. So there, this psoas abscess caused by Constellatus is actually a very rare entity. There are only 2 case reports have been published from 9, and this one is primary psoas abscess, which is caused by the Streptococcus malaria, and they have treated them with antibiotics and source control by pigtail insertion. And the second case report is also from this is from China. They are presented with recurrent vertebral osteomyelitis and psoas abscess caused by Streptococcus constellatus, and then other bacteria was also localized at the time, which is Fusobacterium. So the learning point from the this case is how to differentiate, how to make a diagnosis of psoas abscess and the differential diagnosis of psoas abscess and the organisms that can cause psoas abscess.
Thank you, Sharon. Any questions from the audience?
Get a dental evaluation done.
Yes, dental evaluation was done. She has no abscesses.
Okay, in that case, you said that spondylodiscitis could be either primary versus secondary.
Yes.
In your discussion. What do you think was the cause in your patient?
So they said that even history of falls can be a cause for septicemia or bacteremia. She had a history of fall and was bedbound since then. So she had the symptoms from that time. Only for the past 5 days before presenting to the ED, she had developed features of bacteremia. So I was thinking history of fall, because we do not, she's an immunocompetent patient. There's no comorbidities, no known comorbidities. She's not a diabetic, PBVS was negative. So we are thinking probably history of fall.
If she was bedbound for 2 months, did she have any bed source pressure source? No. Okay. Sure. So you think it was probably a fall and a contiguous spread directly to the spondylodiscitis and then cause spondylodiscitis, or do you think it might have been some other, say you said the commensal throat, whether it was a sore throat associated bacteremia, infective endocarditis, and then spondylodiscitis?
We have done an echo, sir. She didn't have any features of infective endocarditis. So because of the suspicion that there must be any mucosal break of the GI tract, we have also done an gastroscopy today, which shows no mucosal breaks. There is a edema of the mucosa, but colonoscopy is awaited, sir.
Okay. And you said in your case report that the patient had an ASD. Did your patient have any
No, sir.
And what What was the progress of your patient?
So for her, we have started her on ceftriaxone. The usual course is for 4 to 6 weeks with ceftriaxone with metronidazole. So currently she's asymptomatic. We have put a drain and her drain output has almost been 20 to 30 ml for the past 2 days. So we are doing a rescreening and we'll plan to remove the drain and continue the antibiotics for 4 to 6 weeks.
There are no more, any other questions?
How many such organisms are isolated in CMC and what are the sites?
Sorry, sir, I'll look into that.
How often is this organism isolated in CMC microbiology and what are the usual sites? That would be of some interest.
Interest, yes. I'll
So
look
the
into it.
usual description is that it localizes in the respiratory tract. And if it has reached the spine, most probably it must be hematogens, then causing a stress abscess. What will be curious to know is how often are these organisms isolated and from what are the different sites are they isolated, just to understand how common this organism is and what kind of pathogenesis they involve in these places. Do we have
No, sir, I'll look into
something
it.
that would be interesting?
Sure, sir.
Thank you, sir. Thank you, Sharon. We'll move on to the next presentation from Medicine 3 by Dr. Rajesh Kannan on the title Jontranus the Pain.